It is what it is, as they say, huh?
Yeah, exactly. Right.
Right. So just a minute. Okay, so can you all hear me?
Yes.
Awesome.
Okay.
So once again, thank you all so much for making it this morning to witness the third edition of the Global Healthcare Case Competition. Really excited that we have Dr. Rachel with us today. Dr. Rachel is the director of the Institute of African Development. And since we started this competition, they have been really sponsoring us to make all this happen. And so we are really glad to have her in our midst to give us the welcome message. But before I do that, definitely would want to introduce her to introduce her quickly, and then we will go ahead and to do the welcome address. So Dr. Rachel is the director of Institute of African Development and a professor for the global development at Cornell University. Her background is in sociology, environmental science, and international development, and she conducts long-term research in Malawi and Tanzania using participatory research methods to test the impacts of agroecological approaches on livelihoods, nutrition, and sustainable land management for rural communities. Dr. Rachel has over 100 peer-reviewed publications, book chapters, and books in scientific journals such as the Global Change Biology, Global Food Security, Agriculture, Ecosystems, and Environmental and Human Values. She is also the director of graduate students for the PhD in Development Studies and the director of Community Food Systems minor at Cornell University, which provides engaged learning for students with organizations working on sustainable agriculture and food justice issues. So it's my pleasure to introduce Dr. Rachel to give us the welcome address this morning.
Thanks so much for that really warm welcome, and I'm delighted to be here. And I don't want to take up much of your time because I know this is a timed competition, and we've got teams anxious to get started. But I just, as the new director of the Institute for African Development at Cornell University, I'm really excited to hear about this competition. Of course, health issues are so important in Africa. I do most of my work in Malawi and Tanzania, but I am also familiar with Ghana and many challenges facing communities and trying to address healthcare issues. So I think this is a really innovative and exciting competition that you put together. And I wish every candidate the best as you compete. And I think this shows a lot of initiative. And I think it's also quite innovative to bring in the kind of electronic dimension. So I really look forward to hearing the results and wish every competitor the best. And thanks to the judges as well for taking the time out of their busy schedules to convene and to make a decision about the winner. So thank you very much for inviting me, and I wish you all the best in the competition.
Awesome. Thank you so much, Dr. Rachel, for being here with us. Really excited, and we're also very thankful, for sponsoring us through all these years. We don't really take it for granted. So thank you so much. For seeing the value in what we are doing and sponsoring us. So we really appreciate that. So, all right. So we would start the competition. So I would play the video. Team X is our first team. I'll play the video. So Team X the video would be 7 minutes. And afterwards, the judges would have the opportunity to ask questions from the students. And then afterwards, we will go to the second team. So Just 1 minute, I'll pull the video real quick.
Global menace that claims the life of a woman every 2 minutes. When the sun sets today, families of over 720 women all around the world will be mourning. That's over 5 times the number of people taking part in this competition. Let that simmer for a while. Think about it. Ladies and gentlemen, welcome to the 2023 that claims the life of a woman every 2 minutes. We are Team X, and we are here to make a difference. Families of over 720
Let us
women
take you
all
on a
around
journey
the
to
world
the
will be
eastern
mourning.
region, a vibrant
That's over
region of the
5
southern
times the
part
number
of
of people
Ghana,
taking
with
part in
33
this
different
competition.
districts,
Let
over
that simmer
1,200
for a
health
while.
facilities,
Think about
and
it.
internet coverage of
Ladies
about
and gentlemen, welcome to the 2023 that claims the life of a woman every 2 minutes. We are Team X, and we are here to make a difference. Families of over 720
Let us
women
take you
all
on a
around the
journey to
world
the
will be
eastern
mourning.
region, a vibrant
That's
region
over
of
5
the southern
times the
part
number
of
of
Ghana,
people
with
taking part in
33
this
different
competition.
Excuse
districts,
me,
over
sorry, we
1,200
have
health
double.
facilities.
Yes, thank you
Is
so
it
much.
is it double? Is it playing double?
Yes, it
Yeah.
is.
Yes, it is.
Oh, sorry. Hold on. Let me try
And it's a
it.
delayed double.
Oh, my bad.
By the way, it started really strong, Olivia.
Thank
Let
you.
me
Very
check.
strong.
Let me try again. Hold on. Just 1 minute. Hold on.
Global menace that claims the life of a woman every 2 minutes. When the sun sets today, families of over 720 women all around the world will be mourning. That's over 5 times the number of people taking part in this competition. Let that simmer for a while. Think about it. Ladies and gentlemen, welcome to the 2023 OKB claims the life of a woman every 2 minutes. We are Team X, when the sun sets today, families of over
I'll say the
720
same thing
women
is
all
happening.
around the
Same
world
thing
will be
happening.
mourning.
Oh,
That's over
hold on.
5
Can,
times the number
can
of
you
people
end
taking part in this
the
competition.
the
Let
background?
that simmer for a while. Think
Okay.
about it.
All right. Hold on.
Ladies and gentlemen, welcome to the 2023
menace that
OKB
claims the life
Global
of a
Peace
woman
every
competition.
2 minutes. We are Team X, when the sun sets today.
Sorry. You know what? Let me try this one. Hold on. I think maybe I'm using 2 computers. That is why.
Sorry, everybody. We have technical difficulties.
Yeah, I would get this very sorted out real quick. Hold on.
Sorry, everybody. We have technical difficulties.
Yeah, I would get this very sorted out real quick. Hold on.
Global menace that claims the life of a woman every 2 minutes. When the sun sets today, families of over 720 women all around the world will be mourning. That's over 5 times the number of people taking part in this competition. Let that simmer for a while. Think about it. Ladies and gentlemen, welcome to the 2023
menace that
OKB
claims the life of a
Global
woman
Peace every
competition.
2 minutes. We are Team X, when the sun
and we are
sets
here to
today.
make a difference.
Families of over 700.
Yeah.
I think you need to close any other computer you have and only play one computer.
Yeah.
And if you need help, maybe one of us can share the videos?
Hi, Paul. I don't think it's that. He has a double screen, so it's going. Yeah, that's not the problem.
Wait,
He's a genius in tech. He'll figure it out. Give him a minute.
I love the beginning. I do. I can memorize the beginning. I love it.
Global menace that claims the life of a woman every 2 minutes. When the sun sets today, families of over 720 women all around the world will be mourning. That's over 5 times the number of people taking part in this competition. Let that simmer for a while. Think about it. Ladies and gentlemen, welcome to the 2023 OKB Global Case Competition. We are Team X and we are here to make a difference.
Let us take you on a journey to the eastern region, a vibrant region of the southern part of Ghana, with 33 different districts, over 1,200 health facilities, and internet coverage of about 40 to 80%. It's home to Adzo, a young lady with many dreams, cut short by preeclampsia, a common cause of maternal mortality. But why?
Just like the rest of the country, maternal mortality here is higher in the rural areas. Factors that drive this phenomenon include poverty, poor transportation systems, relatively low antenatal coverage, and late initiation of antenatal care. This eventually causes 4 critical delays that lead to an increase in maternal mortality. Delays in recognizing problems, taking timely decisions, getting to appropriate health facilities, and receiving the needed health care at these facilities.
We can change the narrative if we implement strategic changes to decrease these 4 critical delays and thus improve maternal health. We introduce to you the Diapa model. The Diapa symbol is a traditional Ghanaian symbol that means if you pursue a good cause, you'll be supported. And since we are pursuing a good cause, we ask you all to join us.
Diapa model is an innovative, multifaceted model with 6 key components. Our DPAM app, a novel artificial intelligence-powered app with a variety of functions to help health workers register and constantly monitor pregnant women. Women can also self-register, get connected with the closest healthcare provider, start antenatal assessments from their homes, and have 24/7 assistance from our AI. This will help with the early initiation of antenatal care, increased number of antenatal assessments, and the enhanced ability to identify danger signs. The app can also connect women to nearby drivers in times of urgent need. Our DMAMO course will be our central health outreach team made of community health nurses, midwives, medical officers, trained community volunteers, and traditional health service providers. They will play a key role in registering, assessing, and monitoring pregnant women and mothers. We will undertake health education and public awareness programs on a variety of topics like family planning and antenatal care in places like schools and marketplaces. We will also establish a Super Moms Club where women who have gone through the pregnancy journey can come together to share their experiences and insights throughout the outreach programs or dissemination of audio-video recordings. To improve healthcare delivery, we would have an antenatal clinic on wheels that will go around and do monthly outreaches to provide antenatal care to women in the deprived areas of the region. We were elated to find out that OKB Foundation has a mobile clinic, which we will make use of. And as the project expands, we'll purchase another one. We will establish a system of multi-level collaborations as we'll be working closely with the Ghana Health Service and the local leaders to implement our project. Finally, we hope to be able to provide financial and material support by giving women who initiate antenatal care early a Mama's Helping Hand starter pack and establishing a Happy Family Fund to support our model. Because we believe that if mommy is safe, healthy, and happy, the entire family will be happy too.
We envision that we'll face a few challenges implementing our project, but this is how we plan to overcome them. To ensure sustainability of our model, we'll work closely with the Ghana Health Service and local leaders in the region so that they are more likely to carry on with the project even after our 5-year timeline ends. We will also partner with organizations that provide grants and funds for projects, along with various product manufacturing companies to support our fund, a similar model to the approach adopted by the National Cardiothoracic Center. This boosts our product's brand, sales, and CSR activities while ensuring sustainability of our fund. We'd also collaborate with the PRTU to link drivers to pregnant women and mothers who need urgent transportation via the app. Drivers would be assigned tokens which they can use to claim remuneration later if the women cannot afford to pay for transportation, and drivers who have a short wait time will be given incentives. To ensure social acceptance, we'll work with local leaders to deepen our team's connection to various preferred traditional healthcare providers to gain the mutual and maintain the trust of the locals. Not all women have smartphones, so our app will come with a USSD code alternative that allows women to make use of our software remotely. A portion of our budget will also go into purchasing affordable tablets for our Demamo core to enhance data collection and monitoring. And in areas with poor internet connectivity, clients can still use the USSD codes, and members of our team will be able to collect data offline, which can be uploaded to a central database when connectivity is restored.
What then makes the Japan model the preferred and ideal choice? Our solutions are a perfect blend of innovation and utilization of established systems, thereby solving critical problems while maintaining sustainability and affordability. There's data to show that components of our model have produced good results in other similar environments. We can constantly generate data with our app for research, evaluation, and quality improvement. The vast coverage of CHIPS compounds and community health nurses strengthens our model, and the nature of our outreach team ensures readily available human resources. And guess what? People living with disabilities can enjoy the healthcare that we provide. These and more make us better than systems that are already on the market.
To assess our progress, we will use a number of key indicators, including the number of women to start antenatal care in the first trimester, the number of women to have at least 4 antenatal assessments, and 2 postnatal assessments. Ultimately, our biggest measure of success will be a decrease in the maternal mortality rate in the region.
When given the green light, we'd seek to kickstart it early next year. The first few months would be focused on community entry, engagement with key stakeholders, and mobilization of resources. This would be followed by activities to create awareness of our model and the initiation of the pilot phase of our project, most preferably in the Birim South District, where there's a high demonstration of need. Following our regular evaluation processes, the project would be expanded to all other areas of the Eastern region throughout years 2 to 4, and by year 5, the OKB Foundation would gradually step back to play a consultancy role and allow the Ghana Health Service to smoothly take over and run our model.
We'll dedicate portions of our budget to various components of our model, with a portion being allocated to set up our fund. A more detailed budget is available in the appendix for perusal.
Maternal mortality is claiming lives, but no woman should die in the process of giving life. And that is why we believe that with our model and your support, we can achieve SDG Goal 3. We are Team X, and we are here to make a difference, because one life lost is one life too many. Ladies and gentlemen, thank you so much for lending us your ears. You can have them back now.
Awesome. Thank you so much, Team X. That was a great presentation. All right, so right now we will have the opportunity for the judges to ask questions.
All right.
Team Max, that was really, I like your approach. One thing that you mentioned that in regards to sustainment that I think could be, if you can broaden up a little bit for me, what would it look like in regards to sustaining your community health workers, and what kind of training are you providing them?
Okay, so first of all, we designed it in such a way that we are always going to have some people to be in our health outreach team, looking at the kind of people we are targeting. So our community health nurses, the volunteer midwives, medical officers, there's always available resource in these areas. And as part of our model, we'll be having mid-year and end-of-year evaluations. So anytime we do that, we top it up with an in-service training. So at every point in time, we keep training our personnel as we keep expanding our project. Thank you.
Thank you.
So I had a question. In your executive summary talked about an AI, using AI, empowering your app, and I was listening for that in the presentation. Is that still part of the of your structure, and what would AI really do? I mean, AI, everybody's doing AI, right? But how would that interdigitate with your app?
So yes, AI is still part of our solution. The app would actually be twofold, in the sense that first, it would be sort of data processing, in the sense of taking in all the data coming from either the women or the healthcare workers. And then the AI is more going to be used as a predictive diagnostic device to look for trends in symptoms, trends maybe in different areas around women who are either having or not having prenatal care, and taking their symptoms and some of their concerns and formulating it into potential diagnoses to say, okay, you need to go see a doctor or a traditional healthcare worker, or you actually need to go to the hospital.
Okay, thank you.
All right, so
I have a question for Team X. You didn't elaborate on the data you want to get from the pregnant women, the data the medical officers are to evaluate from those women. Would you want to elaborate that to us now, or you do that in consultation with the local health authorities when you are giving the go-ahead?
Definitely a component of that is going to come up when we finally establish our contact with our local healthcare providers. But the kind of data we are looking at collecting is data to help us in the antenatal evaluation of these women and the postnatal evaluation of these women. So basically the same things that we look out for when women come into the hospital to be assessed during the antenatal and postnatal period. These are the same things we are looking out for. Because at the end of the day, we want to make sure that we are continuously monitoring these pregnant women so that if anything goes wrong, we quickly pick it so that we don't end up facing the 4 critical delays that we spoke about. So things like BP, blood sugar, urine protein, stuff like that.
Have you updated your iOS?
So Dr. Polly, you can go ahead and ask your question, and that would be the last question from the judge.
No, it's okay. I think my question was already asked.
Okay.
Good job, Team X.
I'm sorry, I just have one more question. So you did a good job describing the secondary prevention and tertiary care. Have you thought about the primary prevention perspective of your model?
Yes, that was included in our model. That's why we are going to be having public education programs where we are going to be talking about family planning coverage. We are trying to decrease child marriages, decrease teenage pregnancy. So all of those things will come out in the health outreach portion of our project. Yes, please.
Thank you. Thank you so much, Team X. Thank you for the wonderful presentation. We will move on to Team E. So I'm gonna share the screen right now for Team E.
Hello, everyone. We would like to thank the OKB Foundation for this wonderful opportunity. Team E presents our exciting solution in treating and preempting maternal mortality in Eastern Ghana using the Mama Monitor app. So this is the map that shows the region of Eastern Ghana that we are working with today. It consists of a variety of cultural groups with health directors leading each municipality and their medical centers. The unfortunate case in Ghana today is that mothers in labor suffer disproportionately compared to the rest of the world. Ghana has 262 maternal deaths per 100,000 live births, compared to just 21 in the United States. Maternal deaths in Ghana alone cause 14% of all deaths for women of reproductive age, and the biggest causes of these deaths are as listed, including pregnancy and hemorrhage. Other factors contributing to Ghana's high maternal mortality include financial inability to access resources, lack of knowledge about healthy habits in pregnancy, and lack of electronic medical infrastructure. Our digital solution to improve maternal health care in Eastern Ghana is a 4-pronged upstream and downstream approach. 1, organization and planning. Our app makes it easy for mothers to schedule health checkups and receive reminders about important antenatal and postnatal care. 2, monitoring and emergency response. We provide high-risk mothers with vital tracking devices that alert medical facilities about any extreme signs or symptoms. Mothers can also use the app to locate themselves and call for emergency help with the click of a button. 3, education and mental health. Our app provides videos and brief tutorials in accommodated languages about what mothers should be doing for their bodies. Learning modules are gamified to make them more fun and engaging. And 4, electronic medical records. Our app integrates with electronic hospital systems so every doctor can access a patient's medical history and provide tailored care. This will help improve future health outcomes and address the patient data and research gap that exists in Ghana today. Our digital solution has the potential to make a significant impact and meet the UN Sustainable Developmental Guidelines, as you will see in the slides to come, by improving access to care, providing education and support, and streamlining communication between patients and providers, while tailoring it all to the region's different cultures. We can really help to reduce maternal mortality.
Our strategic plan is spread over a period of 5 years. In the first year, we lay down the groundwork, establishing preliminary interactions with the community leaders and health professionals, and also begin education programs on the app. In the second year, we implement the app into the community and provide health monitoring devices, especially to monitor high-risk pregnancies. In the third year, we introduce community maternal health forums to enhance social and mental health support for the mothers. And in the fourth year, we seek to ensure sustainability of the project by establishing partnerships and connections with private donors and other organizations. We then scale up the project after an outcome assessment in the fifth year.
Here we've included a 5-year annualized projection of our budget. In year 1, we allocate $75K to assess maternal healthcare facilities and digital competence and really develop preliminary education programs. In year 2, we allocate additional funding to source technology and distribute them in local regions and prioritize high-risk patients. In year 3, we really pilot healthcare education programs using mobile vans and fund monthly physician screenings using the newly purchased and distributed monitoring devices. In year 4, we focus on ensuring sustainability and longevity of our proposed solution by securing income and cash flow from donors, NGOs, and governmental organizations. We also calculate data from monitoring devices, and we'll use that in year 5 to scale the project and improve user points of improvement.
These indicators will help us evaluate our progress effectively. They are based on clearly defined global and national targets set by the WHO to be achieved by year 2025 in the bid to end preventable maternal death, so as to ensure the sustainable development goals are met by year 2030, especially the goal 3, which aims to reduce maternal mortality rates to 70 per 100,000 live births, and a national target of 140 per 100,000 live births. This goal is attainable as long as we have a good initial implementation and continue inflow from outside sources. And we aim at reducing maternal mortality rates. We also aim at reducing the ANC attendance to 90% and also postnatal attendance to 80% as said by the WHO. We also ensure user satisfaction with the normal monitor health.
Our proposed solution really achieves and meets these goals for 3 main reasons. The first is we're confident in our political support. Leadership is committed to a zero-tolerance policy for maternal deaths and is willing to break down barriers to access, such as transportation, facility inefficiencies, and lack of healthcare awareness. Secondly, our plan is sustainable in that we plan on establishing long-term relations with private orgs, NGOs, and donors to sustain financially secure program for a period of 5 years and beyond. Lastly, there's a proven track record of similar implementations with LHIMS, MOTEC, and T4MCH. They've all optimized maternal health outcomes via SMS reminders, so if they can do that, so can we.
We definitely anticipate some challenges, and one is the language and cultural barriers, which may hinder the maternal health care access. So we plan to partner with town translators in addressing these language barriers, and also to use audio recordings in the community dialects during information dissemination. Our app would also be in the various local dialects and use culturally sensitive language and imagery. The Eastern Regional Public Health Nurse in a press conference last year stated that some of the pregnant women relied on herbalists and prayer camps rather than the hospitals. So in addressing these cultural barriers, we plan to provide effective maternal health education. Finance beyond this 5-year period is definitely going to be a challenge. So we plan to seek funding from international donors and private partners and get a media team to help display our efforts. Technology is definitely going to be a problem. So we plan to partner with government agencies, telecommunication companies to expand internet connectivity to these rural areas, and our app would also have some offline features to be more useful. We know we have a limited number of people who use mobile phones, so we are going to make use of the other channels for information dissemination and partner with some government agencies to provide access to digital technologies. So in conclusion, we are seeing that the implementation of this 5-year strategic plan would help to transform maternal health in the Eastern region. Thank you.
Thank you so much. Thank you.
Thank you so much, Team E, for the presentation. And now we will have the judges ask questions. And so for the judges, it would be great if you can put your hands up so that in that way I can call you back.
Okay.
Yeah.
Okay, I have a question about technology. Technology, we're seeing even here that there was a problem. How important will technology be to deal with everything that comes up? I mean, first of all, I loved what you were doing with the high-risk patients, what you were doing with the videos, making them more like games, but how important will technology be to make this project work?
I think technology is very vital, and especially since it's on the rise. For example, even just in 2022, the amount of handheld phones in Eastern Ghana has gone up near 90%. And soon it's the only way I believe that it can spread. Like we want to spread like wildfire, especially with these emergency monitoring systems. And we want the hospitals to have integration so the patient medical records are never lost and they're always in conjunction with what's going on. So I think it's absolutely vital.
Okay, medical records, will that really work? Because even here in the United States, it does not work very well. Okay, so how can we make it work so well that everybody knows what their medical records are?
I think the first of all, it's all about a perspective. So right now in Ghana, our 2021 evidence shows that based on a survey, one of the biggest issues is a lack of technology. So we first have to inject that into Ghana before we have policy changes. And there will always be issues. We always believe this because patient medical records, even with privacy, will always be an issue, but we have to get the ball rolling. And I think it's a good way to start that process.
Thank you.
That's fine. So Dr. Angela, please, you can go ahead and ask your question.
Okay, thank you. One of the things in most African countries is that when they're using mobile phones, they have to buy the minutes. So for you to sustain your program, have you thought about that process in regards to having the mothers, and especially the region you're talking about, use technology when they have to buy the minutes to talk, the minutes to be on the internet? Your funding, have you thought about that process?
Yeah, I think that's a great question, especially, sure, in terms of longevity of the implementation, like you said. So we've incorporated purchasing and providing and distributing these mobile phones and the minutes associated with them in year 2 and year 3 of our financial projections. And just to walk you through some of that calculations, there's roughly 2.9 million people in the eastern region of Ghana. So about 1.5 million of them are women. And when you look at the statistics and frequency and disease incidence rates, probably 500,000 of them will suffer from poor perinatal care or maternal mortality. So when we divide that population by the funding allocated for year 2 and year 3, roughly 75,000 to 85,000 each, we work it out to about, given subsidies, donors, and partnerships with NGOs, roughly 26 Ghanaian cedi per mother, which is incorporated in our funding. So they won't pay that out of pocket. That's planned within our budget. And to sustain that beyond a 5-year period, we'll make sure we have continued partnerships with NGOs, government, and private organizations.
Thank you. Excellent.
Up to what colleague said, our app would also have some offline features. So it's not only going to be the online features that you would need internet connectivity. You can have some offline features, which would also help the mothers.
Thank you.
So, thank you. So we have our last question from Mr. Joe.
Okay, thank you. So you would think death as an end marker would be a motivation to really move to action, right? To adopt whatever technology would be needed or whatever. It doesn't seem to be the case. Now, you mentioned in your presentation trying to get at some of the barriers related to success of any intervention. What do you think would be the most effective to really get started? To have your intervention, people to be open to accepting it, be that the leaders, the people, the patients, and so forth. That's a conundrum that I struggle with.
Yes.
I think the most. Oh, sorry. Okay, so
Yes.
I think the most important issue with that is stories. I think once we hear the stories of the mothers and we make sure like what they're going through is not normal, that is the very first step. This is why in one of our modules of our app, we have the community forum where mothers can talk about not only their physical signs and symptoms, but any mental health issues they had. And then once they start connecting in that sense and they understand each other, they can know this is not normal. We have to get help. And sure, death has not been a great factor in improving the plight in Ghana, but we agree that once they hear about everyone's stories and their struggles, and once we start seeing improvement, they'll know that they deserve better. So that's our first step.
Yes, and I would like to add up to that. So I mentioned in our presentation that most of the women like to go to the faith healers and then to herbalists. So what we are going to do is we are going to have a community thereby. So we are going to invite these faith healers, the herbalists, the community leaders, the health workers, and then we'll show them the statistics that these are the maternal deaths that have been recorded. So we would like to encourage them. We are not trying to criticize them or say what they are doing is wrong, but we would like to encourage them that as and when they feel they have to refer these patients to us in the hospital, they should do that instead of keeping the patients with them. And when the cases become very complicated, then that's when they refer the cases to the hospital. Most of the time, when the cases arrive at the hospital, it's too late and we can lose the mother or the baby. Thank you.
Thank you so much, Team E, for the wonderful presentation. So I'll go ahead and share for Team V. So.
This is Team V. My name is Joy. I'll be doing this presentation with my colleague, Ilana. My two other colleagues are Tracy and Samantha. According to the 2017 Ghana Maternal Health Survey, maternal mortality accounts for about 2/3 of the deaths of women between the ages of 12 and 49 in rural Ghana. And two main barriers that contribute to this problem are the long distance it takes to get to these health facilities, as well as the high cost of care and travel to the health facilities. Now, progress has been made over the years. However, this progress is still far off the target of the third Sustainable Development Goal, Target 1, which seeks to reduce maternal mortality to 70 per 100,000 live births by the year 2030. In view of this, we've come up with three main strategies to deal with the problem. The first is to improve access to the healthcare by creating a more localized and trusted community health workforce. And the second would make information more available and interactive to the women by enabling them play phone or game-based learning. Now, the image we have on our right will typify what would happen in our game. We'll present the women with key scenarios that they are faced with during a pregnancy period, and this will inform the actions they will take when they are faced with that in reality. Finally, we'll leverage on the OKB Hope Health Van to provide the community health workers with the relevant resources and logistics they would need. Now, this is how our interface for the game would look like. It will be made up of different modules. A maternal module that will focus exclusively on the woman, as well as a neonatal module that will focus on the unborn baby at the point where the woman is still pregnant, or the newly born baby when the woman just delivers. Now, the image on the right would present the woman who will be the person playing the game with different scenarios that she's faced with during the pregnancy period. Feeling nausea, vomiting, and having abdominal pains, and even bleeding profusely, which usually happens around the third trimester. Now, this would ask the woman which actions will require urgent help or urgent response. Her ability to give the correct answer will earn her points or tokens. In this case, we'll present her with flowers. Accumulating these tokens would mean progress being made during the gameplay. Finally, we'll assess their knowledge and their overall understanding of the game through service. Now, we are anticipating a number of threats ranging from the limited access to the smartphones, being hesitant to trust the community health workers, to the overall unwillingness to embrace the game as a tool for positive change. The opportunities we are being presented with here will be to recruit a highly skilled IT personnel to develop the application, organizing information sessions and community sessions where the people will use the tablets and also improve their overall health by playing the game. At this point, I'll hand over to my colleague Ilana to talk about the action plan for the 5-year period.
Hi. So in our first year, we're going to identify hotspot areas within the Eastern region to target for intervention. We will then recruit women to become part of the community health workforce from these regions. The community health workers will collect data on the region, and throughout the year, we will be working with the IT specialists and a focus group of women to help design the game. In the second year, we will recruit patients from the hotspot region and assign them to a community health worker. The community health worker will monitor the health of the patient, and the patient will be able to go to the community health worker with any problems or questions they might have. We will survey patients at the beginning of the year about their current knowledge of maternal health as a baseline measure. In the third year, community health workers will help their patients download and navigate the game. This will mitigate the threat of resistance to using the game as a tool for change. At the end of the year, we will survey patients again to see if their knowledge has improved. Based on the results of the survey, we will refine the game and see what areas community health workers need to be trained in more in order to provide the utmost care for their patients. We will then bring in the OKB Hope Health Bands again to provide care to patients and their newborns. In the fifth year, the community health workers will do a final evaluation on maternal health, and we will send the report to OKB. By the end of the fifth year, patients and their children will graduate from the program, and community health workers can recruit new patients. Throughout the 5 years, we are going to be scaling the game to other areas within the Eastern region, not just the hotspot regions. And past the 5 years, we hope to scale the game to the entirety of Ghana in order to reduce the rate of neonatal death to 12 per 1,000 live births. I will now hand it over to Joy to explain the budget.
Now, we know that a program of this magnitude requires significant funds, so we are planning on allocating a portion of the fund to procuring tablets for the community health workers, as well as the first aid kits and home birth resources to each of the 5 hotspots that will be identified during the initial phase of the program. We would also allocate some amount of money for the game development, which would include the after-sales support, as well as make provisions for stipends for the community health workers within the 5-year period. Now, all of these will amount to about a third of the total revenue, the amounts that will be allocated to the project. The remaining 2/3 will be used to help scale up the project to other hotspots within the region, as well as other regions within the country. I'll hand over one final time to Ilana to talk about the evaluation plan, as well as the key metrics and indicators.
Throughout the program, we will be surveying patients on their knowledge of maternal health and their satisfaction with the community health workers to see where we can make improvements. In turn, the community health workers will be recording data on patients and sending reports to OKB. The key metrics are using data on maternal mortality rates in order to identify hotspot region. We will keep track of how many participants are in our program and how many people have downloaded the game in the Eastern region and throughout Ghana. Lastly, we will record vitals and pregnancy symptoms to see how they have improved. Thank you, and we will now open the floor to questions.
All right, thank you so much, Team V, for the wonderful introduction. Presentation. So we have Pam.
Yeah, I have a quick one. You stated in one of the early slides that the mortality rate of mothers-to-be between the ages of 12 and 49, and 49 struck me as a very old mother age, so I was a little surprised. 12 I could accept, but 49 I could not, and I wondered where this came from. And the second thing is, I thought the budget was very high, and I think that, you know, I would make it a budget like I think most of the budgets that we had looked at were like 350, and your budget is like 1.2 million. And I was just concerned that the budget was much too high to even afford. So those are my 2 questions.
Hello.
Hello.
To take the.
I hope I'm audible.
All right. So about the.
So with
hello,
the second budget.
So my name is Joy for Team V. If I would.
Hi, Joy. You can go ahead.
Okay, all right. So about the first point with the data for the 12 to 49 year age bracket, I think it's a data from the Ghana Maternal Health Survey. So it's a research that was done, and they came up with that statistic. Because the people we are targeting for within that age range, we decided to present the statistics as it is, just so we don't make any alterations to the data that has been gathered by a recognized body. With the budget, I know the fund is about $350,000 US, but our budget was in Ghana cedis. When you do the US equivalents, that would just be about a third of the 350,000. So the 3 almost Ghana cedis
Yeah.
would be around a little over $100,000 US. So the remaining portion, exactly. So the remaining portion
Oh,
we're
I
hoping to use to
see.
help
Thank
scale up the
you.
projects to the other regions of the country. You're welcome.
Okay, thank you very much, Joy.
Dr. Nketia, please, you can go ahead and ask your question.
All right. That was a very creative presentation. The game, I believe, will be very good. My challenge is that what would be the motivation for any woman to play this game? That's it. That's the question.
Okay, so I don't know if Samantha would like to take this. So the whole idea is to be innovative and be creative about how the solution would proffer to the in an attempt to solve the maternal health crisis. I know, considering the fact that we are now in the tech age and the people are gradually getting access to smartphones, they get hooked onto the smartphones because they have the opportunity to play some of these games. We know normally women in the idle times will be playing some of these normal Android games, Temple Run and the rest. We are just trying to blend what they already know, what they already do, as a way of learning and having fun together with solving the maternal health crisis. So, of course, the game will not be new to the smartphone. We are trying to already used to, whilst they are enjoying playing, entertaining themselves and having fun, we are also tackling or dealing with their maternal health crisis, just as represented in the scenario by presenting typical scenarios that they are likely to be faced with, and then that will inform how they would approach that or what solutions they offer to some of these cases.
And I think this actually gets
So to add on what Joy has said, because we're going to introduce the community health workers, they are also going to be our brand ambassadors or our game ambassadors, and they'll create the excitement around this game and encourage people the women to actually play the game, and other family members. So due to this excitement and also getting informed about the game, we can easily recruit young women or women to play the game, whilst also they learn about what they can expect during pregnancy.
All right, thank you. So Dr. Angela, please, you can ask your question.
Yeah, my question is more about actually a follow-up input. So the game is actually a great idea. One of recommendation I would suggest you think about is social media, as well as media training for your community health workers, especially in that area. That's something that I haven't heard utilized a lot. Ghanaians love listening to radio stations. Ghanaians love using social media now. So think about that component in your delivery.
Okay, thank you so much, Dr. Angela. So we would have Dr. Chris to give us the last question, then we'll move on to the next.
All right, so good presentation, Team B. In your presentation, I didn't hear much about your collaboration with health facilities. You know, when it comes to maternal health care, a lot of the mortality is also due to inadequate intervention, and most of the time surgical intervention. And I didn't hear much about that. And how do you hope to also deal with that one? I don't know whether I can respond to it. Because the van, I don't think the van can do surgeries and stuff.
Okay, sorry, you can continue.
Yeah, well, the game can tell them that, well, they will need help, but where are they going to get the help from?
Okay, thank you. In one of the info sessions we had with OKB, they mentioned that there are CHIPS compounds around or close to the CHIPS palace, but then there are other communities that are far away from this CHIPS compound. So our community health workers are going to be connected to this CHIPS compound and also the health facilities around the various communities. And they are also going to work as the first aid personnel in the various communities. So when they do see a patient who does need, or they get communicated to by a patient who needs the service or help of a community health worker, they will then facilitate their movement from their house to the hospital. So we are trying to reduce that gap that is being created by the distance between where the pregnant women stay work close to the women and also help to facilitate those movements between the hospital and the house whenever there's an emergency. Thank
you. All right, thank you.
You're welcome. So we move on to the next team. So Team T, I'll share the screen right now.
Jessica Eisen, a fifth year medical student at the University of Cape Coast. Here are my amazing team members, as well as the outline of our presentation. Moving on to the problem. So according to statistics, every 2 minutes, a mother dies out of childbirth or pregnancy-related problems. That is, 800 mothers die in a day, 300,000 in a year. Unfortunately, 95% of these occur in low or middle income countries, of which Ghana is included. A case scenario takes place in the Eastern region, and here's a map of it right here. The Eastern region is quite dear to our hearts because in the last 3 years, Asubun has undergone a community-based health service program where we've seen healthcare being operated in its primary form. The Eastern region is home to over 2 million habitats and contains 1,220 healthcare facilities. Unfortunately, majority of these face certain healthcare challenges, such as poor management of patient data. As you can see here on this slide, majority of them still use paper-based storage methods for patients' data, which may also account for the prolonged waiting time. Other challenges include lack of transportation and also poor registration to the National Health Insurance Scheme. So imagine some of these challenges or obstacles being coupled with some of the leading causes of maternal mortality here in Ghana, which is hemorrhage or unsafe abortions or hypertensive disorders like eclampsia and preeclampsia. So how then can we solve digitally some of these challenges prenatally, antenatally, and postnatally?
We'll employ our solution, which we call the Opimfo Adamfo model. Opimfo Adamfo means the pregnant woman's friend in the Kwapim Tree language, the most common language spoken in the Eastern region. But before we can implement our solutions, we'll first like to set the scene right. And we'll do this by massively recruiting volunteers, partnering with telecommunication companies to boost their network coverage in these areas, as well as partner with NGOs to possibly renovate some of the dilapidated buildings in the communities. Our very first strategy will be to provide a lot of education and information. And we are going to do this by regularly sending SMS messages to all. And we'll also have broadcasts on our local radio and TV stations, as well as information centers in the locality to demystify common misconceptions about maternal health among the locals. We'll also hold periodic quiz competitions, which will be streamed live to catch the attention of the young people. Our second strategy will be to facilitate healthcare delivery, and we'll do this by indulging in a massive registration of National Health Insurance Scheme to overcome the financial burden towards healthcare seeking. We'll have online training sessions for healthcare workers. We'll also have virtual clinics where patients can meet specialists online, even in their local community, and we'll have toll-free lines where you can call an emergency respondent ambulance service. Some of our volunteers will be people who have cars who will serve as emergency respondent ambulance services. So in a case where you are stranded and you need to quickly get to the hospital, you can call one of these people who will rush and pick you up. So in that case, your best friend may even end up being your ambulance driver. We'll also purchase some remote medical devices. We believe that despite all our interventions, some people will still not be able to make it to the hospital. We are going to train people, equip them with these remote medical devices, and make sure that if you cannot come to the hospital, we will make the hospital come to you in your community. One of our major things we also do is the Opimfo Adamfo app, and this is an interface. It has offline and online features. Some of the offline features are like education, as well as symptom tracking. And then some of the online features will be to be able to call a doctor as well as refer a patient. It has what we call the interactive voice response, which can be seen here for the patient, and it helps you to be able to communicate even in your local language. This is an example of a remote medical device. And our third strategy will be to provide adequate an adequate database for good research, and we do this by creating what we call the CLIMS. The CLIMS is an electronic health record system tailored towards the CHIPS compound and primary healthcare facilities. We interconnect this with our remote medical devices and the app and form a data analytics team, which will monthly give us reviews and help us to know how best to channel our resources. This is a list of all our interventions and the specific timelines, as well as our budget.
We expect our solution to reduce maternal and perinatal mortality, and here are our indicators. We expect at least 90% of pregnancies booked for antenatal care by the second trimester. We expect at least 50% of pregnancies to have the male partners be involved in antenatal care. At least 90% of births occurring being attended by skilled personnel, and at least 80% of them occurring in facilities that are able to give basic emergency maternal and newborn care at least. To ensure sustainability of the project, we hope to make it easy for health personnel to write proposals to companies that are hoping to contribute to the society in meaningful ways. We hope to mobilize communities and invite them to own the project and incentivize key players, and to train staff in the care and maintenance of portable medical devices that will be procured. We expect certain challenges, of course, including the fact that not all people have smartphones. We have tried to circumvent this in our planning by including features that do not need smartphones. We want to create so much awareness that people in the families and neighborhoods of pregnant women who have smartphones will be willing to volunteer them to help when there is need. We hope by proper community entry and engagement and culturally sensitive communication to combat the resistance to change.
So, had a strategy been adopted, as though the woman from a scenario would have had access to inbuilt features in her app, such as having cheaper transportation, and also she would have been able to track her symptoms, where she wouldn't have progressed to the more complicated or severe forms of a hypertensive disorder. She also would have had antenatal care brought to her doorstep via mobile health devices. She and her family would also be massively educated through our radio talks and also through our massive educational programs, and also her health records would have been captured in our ceilings. Remember, so could have been any woman. She could have been your mother, your wife, your daughter, your sister, or even you. Therefore, I hope you are convinced to adopt our painful Adam for model. These are our references, and thank you so much for listening to our presentation.
Right. Thank you so much, Team T. Now it's time for questions from the judges.
I just have a very fast comment. I think that it was the first team so far that really spoke about challenges. And I think that's a very important thing. So thank you for bringing them up, saying maybe a neighbor might have a smartphone, but there are going to be many challenges. And so I thought that was great that you brought up that. So thank you.
Thank you too.
Joe.
Oh, yeah, great presentation. And I appreciate the passionate understanding of why wouldn't families or the men get motivated when the women are dying, right?
Right.
My question, though, is related to the penetration of the Adinfo app. Did you do any analysis on how much reach you would actually get with the affected, age group of women in childbearing age, and what percentage would you actually reach with this app?
Thank you very much for your question. So we know that we are from our research, we realized that over about 60% of Ghanaians now are using smartphones and are on the internet. And so we thought it wise that we should have a platform where people can access that. However, a mistake we can easily make is to always think that when we talk about the Eastern region, it means everybody there is in a very remote area. No, there are some areas with development, and now almost everywhere people are using smartphones. So we put on that feature or the app to cater for people who would prefer to be able to use, access the internet and go there for their solutions. However, we also have another side of our solution, which was the toll-free calling system, which was the messaging system, which was also like allowing people doing broadcast on local radio stations to also reach the locals. So it's like a win-win in both cases. Our app was to target people who are privy to technology and who are interested in or prefer that means. And then we also had the side for the people who are not so tech savvy. Thank you.
Very good.
All right, Dr. Polly.
Thank you so much, team. So you went very quickly through the budget. I was wondering if you can elaborate a little bit more into your vision regarding the budget.
Thank you so much. So our budget is on the 16th. It's on the 16th, our 16th slide. We sent a copy of our slides so you can, yes, please. And you see that we said that we're going to have remote medical devices. We're saying that we believe that not everybody come to the hospital. So we'll purchase these remote medical devices and give it to them. And for that, we budgeted $110,000. We also contacted an app developer, Creative Space, and alongside, yes, and then that one cost $80,000 to do that. For training and capacity building, we put down $30,000 for that. And then we know that we are going to do a lot on radio and TV. So we also set aside $30,000 for that. However, I want to make it known that one of our main things, if you check our sustainability plans, was to partner with these people because there's so much to do and yet so little funds. And we believe that many of these companies also want to bring about improvement. And so we'll talk to them and then get some fee waivers off to be able to push our plans. We, however, also set aside about $50,000 as a contingency fund in case there are any unforeseen circumstances. Thank you. Hello.
Yeah, we have time for one last question, so I'll let Dr. Angela go.
I just wanted a little clarification. So the volunteer neighbor willingness to serve, I love that idea, and also the education of men to be part of the partners. That's great. My question has to do with most Ghanaians have the will to serve. What would you do if, let's say, they don't have the money for gas? Have you thought about that component of your budget in regards to the volunteers, who, especially the drivers?
Okay, included in our budget is an allocation for transport supplementation for that purpose, to supplement the transport of people to the hospitals by their emergency responding volunteers. Yeah, and we also think that as part of our contingency fund, if that allocated fund runs out, we'll be able to supplement with this as well. In addition to funds that we would get from when we have proposed to companies that are interested in helping our project.
Okay, so in addition to that, one of the things we said was that we're going to engage the communities to incentivize these people. So we all need money, but we need money as a means to an end. If there's a way to get some of these drivers and all these people who are volunteers to have some ends met, then would be taking away that whole problem of finances. So in a local community, maybe a fee waiver for some of their children who go to school, or something like some land. You know, in our communities, we may not necessarily have money, but then we do have land and we do have some things. And so we'll bring the people on board to make that work.
All right, thank you so much, Team T. I think that the time is up, so we'll move on to the next team. So I'll play the video for Team AF.
Neonatal conditions are the leading causes of death in sub-Saharan Africa. Women aged 15 to 59 have a 40% higher mortality rate than men, with 14% attributed to maternal causes. The Eastern region, which is the third most populous region in Ghana, faces unique maternal health issues due to limited access to healthcare. With 60% of the population in marital or consensual relationship, maternal health is a significant concern. Most challenges identified by our team were attributed to limited access to healthcare services, shortage in healthcare workers and health information system. Strategic interventions such as maternal data collection, mobile vans, community health workers, and traditional medicines were taken into account to eliminate these challenging issues. My fellow colleagues will take it from here. Thank you.
The mobile health system for maternal health is a multifaceted and integrated solution that leverages technology to address challenges in maternal care. It empowers women with information, enhances communication, ensures accurate data management, and contributes to improved health outcomes, all while being designed for scalability and sustainability. This is achieved through the following approaches. 1. SMS alerts and short code services. This provides timely SMS alerts to provide reminders for prenatal and postnatal appointments. Short code services offer quick access to maternal health information, empowering women with knowledge. The telehealth services, through phone calls and virtual consultations, connect pregnant women to healthcare experts, overcoming geographical barriers. This enables real-time expert guidance, especially in emergencies. The health information system in maternal health is a technologically advanced and adaptive framework designed to streamline data management, improve decision-making, and enhance overall quality of maternal care. It leverages digital tools, real-time reporting, and geographic information to create a comprehensive system that is secure, interoperable, and aligned with the goal of improving maternal health outcomes. This is achieved through the following points. 1. Maternal data collection. This utilizes digital tools for the systematic and efficient collection of maternal health data, including prenatal and postnatal information. It involves healthcare personnel, community health workers, and other stakeholders in data input. Real-time reporting implements systems for real-time reporting of maternal health data, enabling timely access to information of health trends, emergencies, and healthcare utilization. Through our survey and research, we have identified that digital technologies in the world that support maternal health fail for several reasons. To solve for that, we introduce the following: community engagement and empowerment, integration with existing systems, technological scalability and upgradability, monitoring and evaluation, and cultural sensitivity.
With no doubt, the mobile van has been one of a kind of innovation towards healthcare. Now, we are looking at it from a multifaceted perspective. The first one would like to target the health van on is the mobile clinic chip compounds. Now, the main objective of this is to ensure affordability, accessibility, and equity distribution of quality maternal health service. Now, this will come in 3 stages. The first one is integrating autonomous mobility and telemedicine. The second one will be creating a permanent facility, which is the chip compound. And the third one, but definitely not the least, is ensuring sustainability and maintenance for longevity and upscaling. Now, the second use of this multi-health van project will be a mini emergency ambulance. Now, the main goal is to efficient transfer of emergency pregnancy patients to the primary hospital while providing first aid. Now, the stages include stocking the health van with necessary equipment and first aid, recruiting skilled workers to function in these vans to provide first aid. Now, the third one will be renewal of health insurance. The main objective is expanding choice of healthcare providers, lessening financial burdens, and exercising healthcare as a fundamental right. Now, the stages include partnering with NHIS authorities, which is National Health Insurance Scheme authorities, to provide accessibility to registering and renewing NHIS card for remote areas, and educating community members and pregnant women on how to renew their card with a short code *929#. Now, indicator for success would be increase in the ratio of midwife to the population, reduction in the number of maternal deaths and number of live births, contribution to achieving the MMR of 70 by 2030 as targeted by the UN Ghana, Contributing to the United Nations Sustainability Development Goals, this project is related to the Goal 3, Goal 10, Goal 11, and Goal 17, which is the good health and well-being, reduce inequality, sustainability cities and communities, and partnership for the goal.
As part of the main challenge to maternal health care in the Eastern region, especially some rural communities in the Eastern region, inadequate healthcare workers is also a major problem. To improve this, we are supposed to educate capable members in the community to adapt to the skilled workers, and also ask the government to deploy more skilled workers to the healthcare facilities in the rural areas. To sustain this aim, what we can do best is to make sure we sponsor some of the community members to attend some healthcare institutions, employ more skilled workers, and also improve the working conditions by providing incentives to the healthcare workers who work in these rural areas. Traditional medicine also play a major key role in maternal health delivery. And in these cases, most patients tend to attend to these traditional healthcare facilities based on the expensive nature of our healthcare system here in Ghana, and also based on the unavailability of NHIS drugs to cater for some of the complications they go through. And as such, there's a need to create a link between the healthcare system and also the traditional unit to make referrals from the traditional unit to the healthcare facilities, and also strengthen the telemedicine through enrolling the traditional health workers or practitioners on a common platform to educate them as well. In order to sustain or integrate traditional practitioners in this concept, we believe that reimbursing them for every referral can be a good thing, and also educating them on some critical stages of maternal challenges. With the scale up we have as a team, we believe that with time, people would end up coming directly to the hospital than visiting the traditional centers. Also,
that was Team AF. I think their video cut short because of the time. So judges, you can ask questions now. So Dr. Nketia, please go ahead.
Thank you. That was a very good presentation. And one of your indicators was to assess, an increased midwife population ratio is an indicator to assess the success of your project. How does that become an indicator? How do you improve midwife population ratio by your model?
so we believe that as part of the main factors we made mention of concerning educating some community members in the community to also join with the helping of maternal health cases. We believe that we are going to sponsor these community members who are capable to attend nursing training schools and also gain knowledge when it comes to maternal health and improve the community as well. So we believe in the end, we are going to get people from the community getting education in maternal health and also coming back to support the community as well.
To add up, we realized that in the Eastern region, one midwife is probably attending to 391 patients. And then with inclusion of the chip compounds and also introducing more community health workers, the burden on these midwives would reduce. Because looking at one person attending to 391 people within a year, it's a bit too much for the health workers. And I believe that hinders how well they are able to provide their services. Thank you.
Dr. Leonard.
Thank you, Team F, for the nice presentation. So my question is about sustainability of the project when it comes to incentives and reimbursement of healthcare providers. So how have you thought, how are you going to make sure that the project is sustainable? Because to my understanding, reimbursement has been a way of motivating people, but when the funding is over, then it goes back to square one and impairs the sustainability of the project. So what are the plans to make sure that this project is sustainable after the funding?
Question.
Thank you, Mr. Miller. So we didn't get enough time to talk about limitation and the solution, but then one limitation that came up, can you hear me? Sorry, one limitation that we came up was limited resources. And then with that, we seek to secure funding and grants from government and international bodies that are health oriented. Thank you.
Okay, and also we also embarked on a field experience where we went to some of the regional hospitals here in Kumasi. So we personally went to Kumasi South Hospital, which serves as a regional hospital in Kumasi. And we found out that before delivery, or let's say some few weeks before delivery, maternal patients are asked to bring some items with them like powdered soap, geisha soap, and other things for the baby and also for the mother. So we believe that for the sustainability of the project for funding, we believe we can maybe reduce some of these items for the maternal patients. So these maternal patients will be buying from us at a very low price compared to the price on the market. And this will also generate some funds for the project to run.
So we'll pick our last question from Dr. Angela.
My question has to do with health systems management in regards to, I'm glad you said about visiting Kumasi South Hospital. Have you thought about a collaboration with them where, for example, if you provide a resource for them, such as a mobile van, they will provide resources for your patients who are coming in regards to the STAR program that you mentioned, which I think is really creative, the STAR 929. And the reason why I'm saying that is when someone uses that, who is coming? So if you can work collaboratively with the Kumasi South Hospital in regards to your STAR 929 model, I think that would be beneficial.
Thank you very much.
All right, thank you so much, Team AF. We're moving on to the next team, which is Team M. I'm gonna play the video right now.
Region of Ghana, the Obatampa module presented by Team M. The region has 33 districts, 1,226 health facilities, and a population of about 3.2 million as of 2021. It has more females than males. Some challenges in maternal health care include low antenatal coverage in deprived areas, low skill in delivery, poor referral systems, inadequate logistics. In 1994, Serum Thaddeus and Professor Deborah May designed a module for maternal motility and morbidity, which includes recognizing a need to seek care, reaching facilities, and receiving care at facilities. It's based on these three reasons that we are choosing the Obatampa module.
So the Obatampa module, we introduced the Obatampa module, which contains the first, the second, and the third pillars respectively. Under the first pillar, we have 7 branches, some of which include modifications in rickshaw, which is popularly known as the pragya, and standby boats to transport women across the Volta Lake to hospitals. We also wish to use USSD codes for data collection in rural areas, as well as provide tablets to correlation sites for data collection and analysis. The fifth branch will focus on providing a mobile antenatal clinic, which has been done by OKB, but this time modified to particularly suit the needs of pregnant women, aspects of anomaly scans and placenta previous surveillance, which is the major cause of bleeding and death in pregnancy. We also hope to use BP monitors and urine dipsticks to assess for preeclampsia. We also hope to train and retrain staff on modern obstetric methods, especially the proper use of pathographs to aid in referrals. The major challenge within this pillar is internet access, which we hope to solve by making use of the USSD code system for rural areas and the provision of internet access to correlation sites where such data is analyzed. We hope to solve limited access to specialized care by instituting proper referral systems. And the second pillar, that's preventative and supportive care. We hope to prevent unwanted pregnancies, which is a risk factor for poor obstetric outcome, by collaboration with organizations like Marine Stoops to offer family planning services to women. We also hope to launch our mHealth app, which will seek to revolutionize the antenatal care as we know it, by providing information on danger signs in pregnancy, common disorders in pregnancy, improving follow-up, as well as providing a digital backup to the maternal and child health record book, which was instituted in 2018. The major challenges within this branch is traditional myths around family planning, which we hope to dispel with the expertise of Marion Stokes. Also, access to emergency resources, which we hope to resolve by collaborating with Zipline Technologies to deliver preset emergency packages equipped with mark sulfate, oxytocin, etc., which would have helped a joke in this case from this case study. Zipline Technologies deliver these packages via drones to registered centers in rural areas. The final pillar is education awareness, and we hope to focus on community leaders, maternal figures like your mother-in-laws and queen mothers, who play a role, especially in the postpartum period, as well as the pregnant woman herself. We hope to use SMS systems, information kiosks, radio stations to facilitate this pillar, as well as the usage of regular health outreaches. A challenge to anticipate within this pillar is literacy and language barriers, which we hope to overcome by the usage of visual materials and interpreters where need be. So why do we choose Obatampa model? Time won't allow me to go through the SWOT analysis of our model, but I focus on the strengths, the weaknesses, the opportunities, and the threats. For the timeline of our model, this is what we hope to do within the pilot year with a few modifications in the continuous years. Important months include February, where we hope to launch we hope to institute internet access. May, June, which we hope to train and dispatch requests for data collection. July, where we hope to launch our app. And December, where we hope to scale and expand to other districts. So major events within the 5-year period will include the following. It's our mid-year program evaluation and optimization. We also hope to do further partnerships in our 4th year, where we go in with evidence-based achievements over the 4-year period. And the final year, where we hope to make plans for sustained growth and impact of the program, ready for handover to the regional health directorate. These are simplified steps of the implementation process, which start from the meetings with the regional health directorates to development of content for education, and then it ends with the distribution of necessary resources.
Right, so to deal with our budget, we have divided our budget into 4 major components as far as the Obatampa model is concerned. We want to invest about 55% of our total budget allocation into infrastructure development, and they want to invest about 20% of it into motorcycle and transport modification. We are also hoping to invest about 50% into maintenance and system improvement, and then 10% of it into public awareness and campaign. We will be monitoring our performance by taking record of the first trimester registration. We want to see an increment in the first trimester ANC registration in the implementing districts. We also want to see a huge gap of reduction in the maternal mortality rate, increase in NHIS coverage, and then we will be using quarterly evaluation surveys for pregnant women, health providers, and community leaders to assess our performance. Also, we'll be taking statistics from the Radio Information Center to see how far education is going, and also we want to ensure that our patients' data are always protected as far as their privacy is concerned. And finally, I want to also say that we'll be using emergency obstetric care, EMOC, as a tool to reduce maternal mortality with access to health facilities functions.
So the EMOC focuses on assessing the strength of healthcare facilities by checking the following criteria in the facilities. Hopes use the system to improve referral strategies and access specialized care as we help bring facilities to at least basic. The SDG goals that align with this model include target 3.1, which seeks to reduce global maternal mortality ratio to less than 1,700,000 live births, with no country exceeding 2 times this number by 2030. Ghana is currently at 223, so if we implement this model in a region which covers 10.7% of the population, we hope to make a significant change. Another indicator under here is the proportion of births attended by skilled health personnel, which we covered in our model. The other goals, though similar, is 3.7, which addresses family planning, with indicators being women who have their need for family planning satisfied with modern methods. Target 5.6, which seeks to address the delay, recognizing the need to seek care, where women are barred by their inability to command resources. An indicator here is the increased number of women who make their own informed decisions regarding their reproductive health care. In conclusion, we have spoken extensively about the Obatampa model, which covers 3 pillars supporting each other. Margaret Kenyatta once said that no woman should die while giving life, and it's with this quote that we have presented the Obatampa model. These are our references, and thank you very much for your attention.
Thank you so much, Team M. So the floor is open for the judges to ask questions. All right, Joe.
Okay, great, team. I appreciate you introducing the Thaddeus and Main model. At least you referred to that in your executive summary, and then you tied some of your strategy to the different delay levels. Well, that was great. Question I have is one of the things you mentioned in your, education awareness. You said, no, wait a minute. It was on the preventive and supportive services. You said, you wanted to establish digital systems to help prevent unwanted pregnancies. So how's that going to work?
All right. So with reference to preventing unwanted pregnancies, we identify the fact that unwanted pregnancies, unplanned pregnancies are actually high risk for poor outcomes in pregnancies. So that's why within our video, we mentioned that we want to collaborate with systems like Marine Stoops. Marine Stoops offers reproductive health counseling and family planning services to a lot of people. Right now, they are skilled within the country in the Ashanti region, the Central region, and the Greater Accra region. So we hope to partner with them to actually help us with the family planning methods. And that's how we actually wish to curb the issues of unwanted pregnancies, which in the long run actually help with improved obstetric outcomes.
Okay. Thank you.
Right. Dr. Chris, please, you can go ahead and
answer
the question.
Thank you. Great presentation, Tim. So I appreciate the fact that you attempted to use already existing structures so that you reduce your cost of your implementation. You mentioned that you'll be utilizing vehicles such as auto rickshaws and stuff. So after the 5 years, what are you going to do with the vehicles?
So the vehicles are actually going to be left in place within the various communities actually run. So we had this idea from the Doris Duka Foundation, which actually use these kind of vehicles, ambulance vehicles, to actually help improve health outcomes in the upper regions of Ghana. So with the rickshaw, which I actually mentioned within the presentation, we actually leave it in place within the various tertiary districts and even scale down like to even other areas. So it actually work effectively to transport pregnant women to health facilities. And the whole purpose is for pregnant women, but we actually hope that it's even service other related healthcare like emergencies. So we actually hope to live within the district, because I mentioned that within our 5-year period, the last month, we hope to actually scale down and hand over to the regional health directorate as we act as just consultants to the program.
All right, thank you. To add to that, we are also planning that in the district, at the district directorate level, we'll be forming committees that will work together with the community in which the vans are working from. So when the program is over, the system is still there, the committees are there, and they will ensure that the vehicle and then the machines are in good state always. And then the funds that will be generated will be put into an account and that will be used to repair the machines from time to time. Those are the plans we are putting in place. Thank you.
Thank you so much, Team M. We're gonna move on to the next team. That's Team K. Gonna play the video right now.
This is Team K. We are presenting on digital intervention for improving maternal health in the eastern region of Ghana. In the tapestry of life, motherhood shines as a beacon of humanity. Yet maternal health disparities persist worldwide, and Ghana, particularly the eastern region, is no exception. We therefore seek to embark on a transformative journey to confront these challenges, rewriting the narrative with resilience and hope. As background, the eastern region is the third most populous region in the country with a poverty average of 22%. The poorest district is Kuru-Afram Plains South District with a poverty average of 59.7%. The maternal mortality rate of the region stands as 112.09 deaths per 100,000 live births. To address this issue, digital health technologies offer promising solutions. As proven statement, the eastern region grapples with unacceptably high maternal mortality rates, way beyond the sustainable development goals of less than 70 deaths per 100,000 live births. This situation is further exacerbated by limited digital health infrastructure and low digital literacy levels among the population, and also poor access to health information. To address this situation, there is an urgent need for a targeted and effective digital health strategy over the next 5 years to significantly improve maternal health outcomes in the region. We therefore propose a community-based co-design method to implement our strategy. We are using this method instead of an expert-led method in order to optimize our chances of sustainability. In this method, we seek to empathize, connect with the people at the community setting to understand their unique problems. And this will help us lay out actionable problem statements that will help us develop and implement our digital health strategy that will target the key determinants of maternal mortality. We therefore present our intervention, which is the Maternal Care Connect program. In this program, we seek to design the Maternal Care Connect application. Key features of this application will include SMS messages that will be sent weekly to pregnant women based on their gestational age, and to also remind them of ANC visits. The application will also contain audio messages for women who cannot read. This message will be sent to them in their native or local dialects. It also contains interactive voice response and medically guided decision trees for both the pregnant women and healthcare workers. It also contains preloaded content on key issues of maternal health concern. Other interventions in the program includes health education on the key causes of maternal mortality that will be aired in the communities using audio visuals and public address systems. Our intervention will also include a mobile van. We'll leverage a mobile van that OKB already has that in the communities that will need it. Our aim is to tackle the key determinants of maternal mortality, namely the delays. The delay in seeking care, which is an issue of socioeconomic and cultural constraint, delay in reaching care, which is an issue of accessibility of care, and delay in receiving care, which is an issue of quality of care. Our intervention also contains the key component of safe motherhood, namely family planning, where we seek to decrease the higher fertility rate in the rural setting and also increase ANC visit to at least 8 visits per pregnancy. Our intervention will also educate pregnant women and their families on postnatal and post-abortion care, since these are key determinants of maternal mortality. At this point, I will leave it for my co-presenter to take over.
All right. So now, technology for maternal and child health have demonstrated huge success in other regions of Ghana, mainly in the northern, the Savannah, and the Volta region. And so in our quest to implement a sustainable and efficient and a resourceful strategy, we've contacted the management of technology for maternal and child health, and they have agreed on partnering with OKB Foundation to adopt their initiative, which contains most of the features that we have talked about. Now, we think that this partnership not only has sustainability benefit, but also have expansion benefits. Now, we anticipate some challenges that will come with as a result of our digital our intervention. Now, limited digital literacy in some rural areas. This will be tackled using our voice-guided support systems and trainings. Infrastructure challenges such as network connectivity in remote areas. This will be tackled using our offline functionality. Now, low phone penetration in some of these rural areas will be tackled by OKB donating some dumb phones, locally known as yams. Now, strong beliefs in traditional birth attendance. This will be tackled by collaborating with these people, sharing our vision with them, and talking to them about use of orthodox intervention. For our timelines, for the first year, we are looking at planning and piloting. So in the first quarter, we seek to conduct a comprehensive needs assessment using our community-based co-design method. In the second quarter, we are going to identify target communities and healthcare facilities where our intervention is going to be initiated. In the third quarter, we are going to train healthcare workers in the use of these digital tools, and in the fourth quarter, we pilot in some selected districts. In the second year, we are looking at monitoring and evaluation of our piloted programs for improvement. The third year, we expand our telehealth to cover additional rural areas. The fourth year, we are going to enter into a full-scale implementation where we scale to cover remaining communities. And then in the fifth year, we look at sustainability and quality improvement, where we implement a robust data collection and also a reporting system. We are also going to strengthen our partnership with local health authorities and NGOs. Now, our key indicators, we are looking at a maternal mortality rate targeted below 70 per 100,000 live births, with an ANC coverage increased above 98%. The number of pregnant women that are registered on our digital platforms are also going to be an indicator. The number of women that are delivered by skilled birth attendants as opposed to traditional birth attendants, also with a user user satisfaction survey in the form of interviews. Now we have our budget here, and then for sustainability, we are looking at strengthening partnerships with our local health authorities and NGOs such as the Savannah Signatures, the initiators of the technology for child and maternal health. We are also going to integrate NHIS into our program, and then a robust data management for future improvement. So in summary, what we are saying is that Maternal Care Connect is going to be a holistic and an innovative healthcare initiative that's going to be designed to transform maternal health outcomes in rural communities facing challenges through a blend of our offline first technology, our community engagement, and our culturally sensitive programs. We know that this program will be able to reduce maternal mortality as it addresses the critical delays by our accessible information, our decision support system, and our healthcare resources. Maternal Care Connect will empower these rural mothers and their families to help them navigate the challenges that come with maternal care as a result of their community, and they will be able to save their lives and nurture healthier communities. Thank you very much. These are our references. We are open up for any questions.
Thank you so much, Tim K. The floor is open for the judges to ask questions. All right, Joe.
So great, thank you. Also my favorite 3 delay model. In terms of accessing women and getting information and the recognition and so forth, what strategies or tactics did you consider once a severe problem is identified to quickly get the mom to help, be it to a facility or to a practitioner or someone who's going to do an intervention that might save the life of the baby?
Okay, anyone online team?
I mean, maybe that wasn't part of your strategy, but just a question I had.
Question.
Right, Tim K, I can see you are online, but one of you is muted.
Yeah, please, can you hear me?
Yes, we can hear you.
All right. I didn't quite really get Joe's question. If he could come up.
So the question was, once the recognition of the problem is achieved, so that the mom is in trouble, she's bleeding, she has a significant issue. What tactics did you consider to try to get her help quickly? Be it by access to a practitioner, a facility, or whatever.
Okay, so for such a situation, our intervention has medically guided decisions that will help in early detection of complications during pregnancy. So for a woman that has experienced complication, we expect that the intervention will be able to grant that woman to detect the complications early, to seek help using our application that they can call and access health information.
Okay. Yeah. So more on the information side. That's cool. All right. Thank you.
Thanks, Angela.
Thank you. My question is, your approach is also adding a pilot perspective, which is nice. My question is, have you considered a listening session, like a town hall, especially in the rural areas, to gain that cultural perspective? I know you have an insight because you mentioned that in regards to traditional healers and so on and so forth. But in the pilot stage, have you considered a listening session or a town hall?
Yes, please. So in our intervention, we included a community-based needs assessment where we seek to engage in community engagement to get the views of the people, to include them in the implementation process from the start. And that will help us get their views and on the key things that are complicating maternal health outcomes in their respective communities. And that will help us to tailor our intervention to suit such communities.
Thank you.
Thank you. So we'll pick our last question from Dr. Nketiah.
All right. That was a good presentation. You rightly identified a challenge. That's the over-reliance on the traditional healers in many rural areas. But your attempt to solve it, I didn't quite get it. Did you say you would have a discussion with the traditional healers? I really believe not to take them off their source of income. So how do you tend to plan to achieve that that goal?
All right. And so we are not, no, definitely not. We are not trying to take them off their livelihood. But what we are going to do is we seek to collaborate with them. We seek to let them know some of the complications that come around, because we believe that, let's say, as part of their job, they mostly are responsible for delivering these people. But in terms of complications, where the woman is bleeding excessively, they would not be able to do that. And so in terms of, as part of our collaboration with them, we seek to let them know that in such cases, what they should not continue trying to let these women give birth on their own, but immediately locate a health facility and send these women there. So as part of our collaboration, we are going to involve them in our trainings. We are going to involve them in the intervention, so that they would be abreast with what to do, but not this, because they are also very important, because definitely the women are not going to have access to direct healthcare directly. So we are going to involve them, by letting them know their limits and as to what they can do and what they cannot do.
To add to that, we also seek to educate the traditional birth attendants on the use of orthodox medicines in non-orthodox settings. So those training sessions will empower them about more orthodox interventions that will help them detect early complications during delivery.
Thank you, Team K. We will move on to our next team, Team N. So I'm gonna play the video.
Hello, everyone. Thank you all for taking the time to review our submission for the 2023 OKB Hope Foundation's Global Healthcare Case Competition for Maternal Mortality. We're Team N, and today we're so excited to share our solution, Mapo Mude, and take you all on a journey over the next 5 years with us. In the first half of today, we'll go over the background and review our proposed strategic solution, innovation, and implementation for logistics. In the second half, we'll take a look at the challenges and explore the future opportunities. With that being said, I'm going to pass it to Anjali.
Thank you, Gallion. In our previous presentation, we talked about the issue of maternal mortality and morbidity as a crisis of both affliction and access. And today I want to elaborate a little bit more about the affliction part of that statement. If we look at the SDG 3, good health and well-being, the UN wants to reduce maternal mortality to 70 per 100,000 live births and neonatal mortality to 12 per 1,000 live births by 2030. But in the Eastern region, this goal has not yet been achieved. Our proposed solution is a 5-year project entitled Mapo Mude, or Women's Health, and we propose a variety of patient, volunteer, community, and provider-centered technology solutions to address the UN's 3 delays to healthcare and maternal health. Together with the patient, provider, policymakers, and leaders, and our volunteer and analyst team, we can achieve the SDG goal and make a meaningful difference in maternal mortality and neonatal mortality in the region. Now, I want to pass it off to Hilton to talk about more about our strategies.
Thank you, Anjali. So our strategies to achieve the Mapo Mude, as has been aligned with the SDG 3, the target 3.1, 3.2, 3.7, and 3.8. Our first strategy has to do with the use of a mobile application, a short code, and a hotline. This mobile application is going to ensure that there is access to reliable medical information and also used as a form of telemedicine. So there is going to be incorporated an AI component, which pregnant women and their mothers will use that to have their symptoms triaged. So they could speak their symptoms, or they could type in their signs and symptoms, and then with the triage system, just as used at the hospital, the AI component will identify and place where the category in which they belong to. The app is going to have 2 end users, not just like the ordinary apps that have been in the system, the pregnant women and their mothers, as has been already mentioned, and then the healthcare provider. The healthcare provider would be able to use the app to communicate with the pregnant woman to assess evidence-based medicine, and also use that to communicate with specialists at other higher health facilities. And with that, we believe that with this app, it is going to help to reduce maternal health issues, as has been highlighted so far. The next strategy is the registration and tracking. We want to collaborate with the different health directorates with community health leaders, with community health officers, with volunteers, assemblymen, and other notable people in the communities to register all pregnant women and mothers so that they will be able to be followed up and tracked, and then we will link them up with 2 health facilities available in their vicinity. Our third strategy is the mobile clinic and public education. There still remains other places in the eastern region, like the Dwarf Island areas, which is inaccessible to transport and other, and also very, very minimal health facilities available for healthcare. So we intend to leverage OKB van to provide scheduled healthcare to those areas at scheduled period. We'll continue to intensify public health education to reduce misinformation, to empower people so that people like Ajo would not be misinformed to make decisions that is not going to help health. The fourth strategy is the health information management. We want to build the capacity of health professionals in digital technology for data management and decision making. We realize that most health clinicians are not so much interested in data, and they wait till the end of the year where the health information officer will analyze the data and let them know their performance, especially in maternal health. But at the end of the project, our 5-year project, we want health clinicians to be empowered to be able to analyze their own data and make decisions out of it to help improve maternal health. Lastly, our strategy is advocacy and sustainability. We will want to advocate for equitable distribution of health facilities and health professionals so that areas in the eastern region that are lacking will have physical access to these health facilities. And also, we will intend to collaborate with communities to establish what we call the community self-help project to address maternal health issues such as building of healthcare centers, implementation, logistics, and then timelines. So, in the first part of the project, that is 2024, we intend to have our regional entry baseline study, community and stakeholder engagement, which will continue to the end of the project. Application development will start, and then in 2025, we will pilot the software. We will start initiating our programs in 2025, including the deployment of the app, registration, monitoring, and then health outreaches. Our midterm evaluation will be in 2026. Advocacy programs, community self-help project, and monitoring and supervision will continue from 2027 to the end of the year. By the last quarter of 2028, we will have our terminal evaluation and then learning. Our budget for the entire project is $350,000 US, and we expect to use over $100,000 for the mobile clinic and then public education. Our mobile application and short code and outline, we intend to use 75,000. Advocacy and sustainability will be 55,000. Registration and tracking will be 55,000. Health information management will be 40,000. Monitoring and evaluation will be 25,000.
With regards to the overall indicators, we have indicators specific to the impacts we hope to achieve with our intervention, as well as the process and our specific strategies. For the impact, we have 2 main impacts that we foresee as a result of our strategy plan. Firstly, increased access to maternal health care, and secondly, reduced maternal and neonatal morbidity and mortality. And the indicators for both of these both of these impact components are related to the SDG 3 targets and the indicators suggested there.
The development of our strategy, we foresaw some challenges that may be faced through its implementation, such as transportation, language barriers, cultural beliefs and practices affecting community acceptance, and low internet penetration. To mitigate these issues, the project incorporated GIS technology to map healthcare distribution, divide the region into proximity areas for easy access to facilities, patronize the use of motorbikes by trained volunteers to remote and inaccessible communities. Health campaigns and training will be provided in local languages and mostly by trained community health leaders. Then community engagement and participation will be promoted with a trained community review board overseeing the project to facilitate cultural assimilation and maximum community acceptance. Clients' data and privacy will be safeguarded in line with the Ghana's Data Protection Act and various ethical principles surrounding healthcare. Capitalizing on existing external technologies like the digital patient registry, offline messaging and teleconsultation calls, patients can still access healthcare remotely despite poor internet penetration. Then partnership with local hospitals and training healthcare providers will further integrate technology into the local communities, which will help in the implementation of our strategy.
We really want to leverage the technology, fostering and ensure continuous evaluation. We believe we can make a significant difference in maternal health outgoing in Ghana. With Mapomudin, together, we can pave the way for a healthier future for mothers and for the newborn in Ghana. Thank you.
Thank you so much, Team N. Now the floor is open for judges to ask questions. All right, Dr. Angela.
Can you tell me a little bit more about your sustainment plan? I really do like your indicators broken out into impact and process. I just would like to know more about how you plan on sustaining them. you mentioned the outcome sustainment, but if you can elaborate more on the rural portion of it, I love the fact that you spoke about that too.
I can take this question. So first off, thank you so much. One of the big goals of our intervention is to have a sustained impact on this community over time during the main period that our intervention is in place, but also creating a framework for after that. So if you look at our strategy indicators and the strategy they were proposing, part of it is dedicated to maintaining this app and this system that will take in this data and connect them to the local healthcare system. But also part of it is creating a framework by which people can maintain connection with the healthcare system and generating this information for them to stay connected. So first, I want to draw your attention to, in our mitigant slide, we talked about using GIS software and connection with the local community. We recognize that although we would of course try and maintain funding for this initiative over time, there may come a time where we aren't able to maintain things such as the app anymore. However, by using GIS software to maintain a proximity region to local hospitals, and also having a real connection with the local community, local religious and community leaders, we hope to maintain a social and geographical network by which they can continue accessing care. Thank you.
Thank you. Jill.
Yeah, nice work. On one of your strategies, more of a minded question, but I want to ask it. One of your strategies was the mobile clinic and public education, right? And you said the resource needed with a mobile clinic vehicle. So, A, were you intending to purchase those, and B, if so, what was the cost component of that in that year's budget?
I can take this question as well. So the reason that we decided to do a plan that half focuses on personal technology and half focuses on technology of the healthcare providers is because in this case competition, we're working with resources that OKB has. So one of our mitigants was to address the fact that technology penetration is low, especially in rural areas. And for the mobile clinics in question, we'll be mostly using the OKB vans and mobile healthcare facilitated by local healthcare facilities. So as part of that, with regards to the sustainability question from earlier, by avoiding heavy expenditure on behalf of this intervention and utilizing resources that already exist, we hope to redistribute some of our funds in that area to other places.
Okay, yeah, good answer. So maybe my question is for Osai. Osai, how many vans are you going to get?
Yeah.
Oh, sorry, you're not part of
it. No worries. I'll let you know soon.
Yeah. Okay.
Yeah, I think we'll pick the last question from Dr. Angela, and then we move on to the last.
I apologize. I already asked my question. I'll put my hand down. Sorry.
All right, no worries. So we'll move to our last but one team, Team Kielsa. Gonna play the
Hi everyone, my name is Frank and this is Team Kyo. I'm here together with Samuel, Catherine, and Grace. We'll be presenting on Digi Mama Care. So despite efforts to reduce maternal mortality, we still haven't hit the Sustainable Development Goal targets, and maternal mortality still accounts for a significant proportion of all deaths. The Thaddeus Means 4 delays model seeks to explain the reasons behind this. Now, 830 women die every day from preventable causes related to pregnancy and childbirth around the world, and a woman dies from a pregnancy-related cause every 2 minutes. Those are some interesting statistics. And according to the Sustainable Development Goal 3, which says good health and well-being, its first goal is to reduce maternal mortality, and this is really important. So the Thaddeus Means 4 delays model basically says there's a delay in recognizing need, delay in the decision to seek care, delay in reaching the health center, and delay in receiving care at the health center. So we are proposing Digi Mama. It's a comprehensive 5-year, $350,000 initiative, which leverages digital technology and community engagement to revolutionize maternal mortality by addressing the problem at the level of the delays. So for our first component, it's a trained clinical health agent, and these are important parts of our programs, and their responsibilities include education, providing digital and valuable insights on pregnancy, maternal health, also facilitating onboarding on our digital platform, ensuring informed decision-making. They promptly address questions and concerns, engage with the local communities, and facilitate onboarding on the platform. Also, we also have the digital platform itself called Digi Mama, and it's a user-friendly multilingual platform which is accessible via calls and texts, and it uses AI and natural language processing for query management, offering immediate responses for urgent matters. And For implementing this platform, we register expectant mothers and women in general on the platform through our health centers, community outreaches, DigiVan services, and other outlets. People can also register on their own. Mothers start receiving prompts and messages on general health, pregnancy information, and also it encourages health-seeking behavior based on the stage of pregnancy. Mothers can also easily ask questions about pregnancy and general health, as well as more urgent questions such as pregnancy-related complications. So the AI model triages the questions into urgent and non-urgent questions. The urgent questions are addressed immediately by trained clinical help agents who get in touch immediately with the woman and help her reach the nearest health center for further management, or help get the mobile vans close to her. Also, for the mobile clinics, these are extensions of healthcare centers which are staffed by relevant resources and skilled professionals, which offer a wide variety of health services to people in remote areas. We also would organize public education campaigns and also foster community engagement. So we will start awareness campaigns to educate the communities on maternal health care in general. We also conduct workshops and community meetings to engage with women and families. We will promote the mobile van services through these meetings and also encourage registration. This is to prioritize collaboration with local stakeholders and also emphasize the cultural sensitivity and community participation, and to ensure that the program is deeply rooted in the local context, utilizing methods which are culture friendly. Pay phones are also standing phones, which are placed at vantage points for women who do not have access to mobile phones or digital devices, and makes it possible for them to also access their services. We're also looking at building waiting houses, which are close to health centers for women who are close to labor or close to term, so that they can come to these waiting houses and lodge there, so that when they go into labor, they can be attended to by trained and skilled health professionals or trained birth assistants. This is our attendance. This is to avoid, this is especially for women in far areas where there are no health centers available. Data-driven approach and sustainability. We are looking at long-term funding strategies through grants and partnerships for maintenance and expansion. Also, we seek to place less emphasis on paper and make sure everything is digital. Our quality improvement methods seek to focus on 4 main things: staff training and retraining to make sure our personnel are up to tasks, updating technologies as needed, collecting and analyzing data to assess for trends, and also to improve the model accuracy to make sure the information provided is precise. And also, we will ensure our mobile vans, pay phones, and waiting houses are in working conditions.
To measure the success of our platform, we want to kind of assess how much attendance comes from our mobile clinics, along with the number of women who sign up for our program and the number of women who actually use it, along with tracking who comes to our public education sessions. We also want to assess the response times for urgent queries and the user satisfaction rates through surveys and feedback, and then measure the sustainability of our program by the revenue generated. Overall, to see success, we want to see a reduction in maternal mortality and complications. Looking at our 5-year plan, the first year we want to allocate about $100,000 for mobile van development, public education and awareness, clinical health agent training, and AI model development and data collection. For year 2, we want to allocate about $80,000 and continue our AI model development and launch our digital platform. For year 3, we want to allocate about $70,000 to scale our digital platform along with our mobile vans and then any quality improvements. For year 4, we want to allocate about $40,000 for implementing payphones and waiting houses and any sustainability planning. For year 5, we want to allocate $40,000 for any continuous quality improvements that we can make. And then we have about $20,000 for any unpredicted costs for the 5 years.
So in implementing our DigiMama projects, we might face some challenges, of which we've categorized them into 5. And the first one is limited digital literacy, where we conduct digital literacy campaigns, and also resource constraints, so we seek partnership with government agencies and other non-NGOs for resource support, and we mobilize human resources by training locals, and thereby also for the third one, with the cultural barriers and ethical barrier on the use of the AI, we engage the community leaders and culturally competent healthcare workers, ensure users understand AI is just helping workers and not solely handling their health. And with the 4th challenge we might face with the mobile van accessibility, we will develop a well-planned itinerary and collaborate with local community to secure more vans. And with the last challenge, with the language barrier, We will make use of local health professionals and trained locals. Use of AI translation programs too may be added. And in conclusion, we say Digi Mama is a holistic approach that uses approach to maternal health care in Ghana's Eastern region, using digital technology in the community to reduce maternal mortality rates in the Ghana's Eastern region. Thank you.
Thank you, Team Q. So, judges, the floor is open for questions. Okay, so Joe, please, you can go ahead and ask.
No, go ahead. I'll let others, I'll hold off.
Oh, okay. So, Dr. Chris.
All right, thank you for your good presentation, Digi Mama. A lot of your stuff will be based on the internet. How do you hope to address connectivity issues, penetration issues with this project?
Hello, thank you so much for your question. My name is Frank and I'll be taking this question. So it's not necessarily over the internet. We plan to use the mobile telco service like short codes and then, toll-free services. For example, the way you can dial call 100 and you can access the MTN help center. It's something like that. So you can either call and it's multilingual. So you can choose a language you'll be comfortable in and you can take it from there. And for the text service as well, it will definitely require some airtime, but if that's also a challenge, that's why we've made payphones available at Vantage Points, which also do not require any money whatsoever. So that makes it easy to access the platform. So it reduces the need for internet. And yeah, thank you.
All right, thank you.
Dr. Angela.
So a concept that is being looked at in regards to community health workers is also patient navigators. Your proposal concept do well with community health workers and patient navigators. Just a thought of you to think about that, because the health systems, majority of the time, people don't get access because they don't know how to navigate the system. So if you do have community health workers, just think about the concept of patient navigators that might be able to help navigate the systems. So just because you have the resources doesn't mean they know how to navigate it. Just a thought.
Thank you so much. Please, we will take that into consideration. In our solution for that, we thought of using the trained clinical help agents to help the patient. So they help with the onboarding and navigating through the system. But we'll definitely look at more ways you can improve that. Thank you.
You're welcome. So I'm Joe. We have some time for one question. Are you good?
I can ask my question?
Yeah.
Chris has got his hand up, but I think he already asked his, right?
Correct.
Again, this Dennis, you introduced the fourth delay, which was community to take responsibility, right? What are the hooks in your project that would allow that to happen over the course of the 5 years? So I'm talking about how would you achieve the fourth aim, community to take responsibility? So really for them to grip hold and want it to achieve the outcomes you're trying to get.
Okay. Please, so if I understand your question, you're asking about how we will help the community to also get on board with the program?
Yeah, and for them to really take responsibility. So now you're not trying to push your idea, they're pulling it.
Okay. Thank you so much for the question. So how we intend to, foster community engagement is by making use of locals. We first want to make sure that the stakeholders and the community leaders first understand the relevance of the project we are bringing on board before we introduce it to their members, so that when we are going, we know that we also take their ideas as well, so that before we introduce the solution we have to their health centers and to their vantage points, we are actually integrating their culture into the solution we are also proposing, so that it's something that they can also maintain and know that, okay, it's just like the services they've been offering via short codes and like I mentioned, the 100, the normal services they are aware of. It's just this time, it's a portal for them to access health services very, very fast and immediately.
Okay, so in adding up to the question, to make sure that every community activity that you want to implement in a certain community, you have to first of all pass through community entry. And also we got to realize that a proper community entry will foster a proper implementation of a program.
Okay, great.
Thank you so much, Team Q. We have our last team, Team I. I'm gonna play that.
Mariana, and I'd like to introduce our team, Project Obatampa. We're here delighted to be able to participate in this competition to assist in creating a more equitable and impactful reproductive healthcare system in Ghana, and hope that the strategy we developed and will present today can be of use in ameliorating the situation. Specifically, today we'll be focusing on the alarming rates of maternal mortality in Ghana, especially in rural communities. Currently, Ghana faces 310 deaths per 100,000 live births, which accounts for 14% of all deaths, and we would like to lower that number to an MMR of 70 by 2030. As such, we'll be employing a strategy that addresses the main issues Ghana faces, including lack of early identification and treatment of pregnant women with high-risk conditions, difficulties in transportation to treatment centers in rural areas due to long distance, poor health-seeking behavior linked with low patient education, and unwanted pregnancies due to poor contraceptive education. Therefore, we will be focusing on minimizing 3 delays: a delay in recognizing the problem, a delay in seeking treatment, and a delay in receiving care. To do so, we will prioritize increasing education on and access to reproductive healthcare, specifically through a new app, Obaton. We'll first discuss the exact strategy, then go over the assessment and the budget.
All right, so concerning our strategy, we will first begin by wanting to know what some information on the ground. And based on data from the UCC School of Medical Sciences, we know that most females seek antenatal care at a CHIPS compound, and also about 50% of these females' choice is based on the quality of care provided, and they're usually just 2 healthcare workers at the CHIPS compound. So we begin our intervention by community entry, where we would have to communicate our intentions with the traditional governments in this area and seek their permission. So in the first year, what we intend to do is to begin by identifying a particular district in the eastern region, which for now we are thinking they are Chimansa district, since the University of Cape Coast School of Medical Sciences have done extensive research in that area for almost a decade now. So what we just have to do is to carry out a needs-based assessment on the health infrastructure, what is already being done by other health bodies and the government, and also to train stakeholders and traditional birth attendants and any other person who will be helpful in us rolling out our plans, to train them on digitization of health services, like moving from paper-based to electronic-based health data collection, the use of automated blood pressure devices, and also we would also like to begin reproductive health education in schools. And we'd also, within the first year, collaborate with telecommunication agencies in strengthening internet access in these underserved areas. And in the second year, we are going to continue with the training and capacity building of these human resources, and also it's within the second year that we begin the official launch of our Obatan app, with the rollout of certain accessory health devices like the wearable devices or wearable blood pressure watches that will be able to detect increased heart rate and can alarm health workers or the pregnant mother of suspicious vital signs. And we continually create awareness within the second year with the help of traditional leaders, churches, local radio, especially on depression too, which is one key mental health factor that happens during pregnancy, and also facilitate in-home visits for pregnant women living far from hospitals. Now, for the app itself, we have a basic and an advanced edition. So the basic edition is a mobile-friendly app which consists of educational videos. It's integrated with a health record database, which contains health information on pregnant women, and it's also synced with wearable devices so that data is collected around the clock. And the advanced edition will be used by people with smartphones, and on that one, calls can be scheduled with health workers, and online communities can be also created to discuss certain mental health issues during pregnancies. Now, within the final year, that's the 3rd, 4th, and 5th year, this technology will be upgraded, partnerships with NGOs will be sought, and quarterly events with expectant fathers to be arranged to get the men involved. In the final year, there will be documentation and compilation together with the Ministry of Health to increase health workers that are sent to these areas. So all in all, it's an integrated approach where there is good communication between the community health nurse and the pregnant mother, and this community health nurse has the responsibility of taking as much data as possible from the mother, her blood pressure, important vital signs, her heart rate, and this is all keyed into the Obatan app. and then the mother is given a wearable device, could be a watch, which measures her activity levels, her heart rate. And during risky times, especially when her heart rate has gone very high and she's having certain signs like headaches, the wearable device can send off an alarm, which will prompt the mother to either call the healthcare worker, or the healthcare worker herself will receive the alarm at her end because it's synced, and then her blood pressure and other things can be checked in order to prevent any unwanted complication.
Hello, I'll be talking about assessment and challenges. The following are going to be our indicators: maternal mortality rate, early detection of pregnancy-related complications, attendance antenatal care, postnatal care attendance, interest by other surrounding communities, and finally, user satisfaction and feedback. Now on to anticipated challenges and their solutions. The first is digital literacy barriers. In the very first 2 years, we are going to hold digital workshops. And our app is also going to have simple interfaces which can be used by all. For users who have smartphones, there's going to be an option to call healthcare workers whenever they are stuck. Second is limited digital access. Our app is going to have offline services, and there will be centralized areas with digital access for information. We will partner with MTN, which is a telecommunication company in Ghana, and the government to invest in these underserved communities. To tackle conservatism, we are going to discuss and collaborate with faith leaders and traditional leaders to influence the people on our behalf. Finally, the success stories and positive outcomes will speak for themselves, and more people will be drawn towards our projects.
In order to come up with a budget, we decided to look at averages in various categories, including app development, human resource development, transportation costs, tablets, computers, and miscellaneous medical costs. For the app development, we chose $10,000 because this is, on average, how much money it takes to develop an app like the one that we're creating. For human resource development, we chose to employ 5 teachers, made up of religious leaders, community leaders, and healthcare workers. Since this is supplementing their actual job, we will be paying them $3,500 per year for 5 years. For transportation costs, we chose 5 vans, 1 for every district that we're starting in, and we can adjust this as time goes on. For technology, we chose 2 tablets per district and 1 computer per district. Lastly, for the rest of the budget, we decided to include miscellaneous medical costs, which would include costs for ultrasounds, maternity clothes, beds, and other such expenses. This would total the total budget that we've been given, which is $350,000. The rest of our slides shows the credits for our references, articles, and photos. Thank you for listening to our presentation, and we hope that with our strategy, we can make an impact.
Thank you so much, Team I. The judges, the floor is open for questions now. All right, Dr. Nketia, you can go ahead. I think you're on mute.
Okay, sorry.
All right.
Thanks so much. That was a very good presentation. One of your indicators are to assess the interests of other surrounding communities. How do you intend to measure that?
All right, so with that, that may not be able to be measured quantitatively. So it will be through qualitative methods that will be able to measure that. So for example, it's through when people we collaborate with leaders. So for example, working in these communities, one time a leader can tell you that, oh, this community nearby have seen what you are doing here and they want you to come on board. Then that's when maybe we can go there and we do what we have already begun in one community. Then along the line, then we can assess the progress of our work through quantitative methods like questionnaire administration, and that's when we can put values on that. But to just give us a vague idea, that will be just through qualitative means.
Questions from the other judges? Hey, Joe.
Yeah, just you referenced, might have been in your executive summary, that you based your model off a intervention in Pakistan. Is that correct? And how is that working? How is that one working? If that was the underpinning of your model? Am I correct in that? I think I had the right. I think it was more the executive summary. Yeah, executive summary. Because if you're basing it off a previous model,
Team I.
Yeah, I think it's team.
All right. So it was part of it, not the entirety of it. So part of it was just based on we cited a number of articles. So I think the parts that were based on the ones on the Pakistan was how they use the app, especially, yes, but much of it, especially with the van and the using of the wearable devices, were based on our own thinking after reading other papers. Yes, okay. I think another group member can support with how the success rate was with those ones.
Yeah, that's okay. So quickie, also you executive summary, you talked about ultimately a $30 million budget. Did I read that correctly?
Yes, that was a typographical error.
Oh, that's
it was. Oh, good.
Okay. Also,
I was gonna say these guys think big.
Yeah, really.
Also, by the way, so about the Pakistan app, the reason that we found out about it was because they actually did do a good amount of work, and they won first prize for a maternal and neonatal health award. I think from when I was looking at it, it was the Commonwealth Digital Health Awards. Because of the novelty, innovativeness, and their ability in actually being able to ameliorate some of the issues. So it was very successful, which is why we decided that a similar app could be very beneficial in Ghana as well. And that's why we based it off of that app specifically, but we also looked at the culture in Ghana, which is different to the one in Pakistan. Which is why we also included the other cultural interventions and the education that we want to implement as well.
Okay, great, thank you.
Awesome. So Team I was our last team. Thank you all so much to all the teams and to our wonderful judges for evaluating all these presentations. At this time, we're going to move the judges to a breakout room for them to deliberate and then come up with the top 3 teams. And so I will encourage the participants to hold tight. We should be back a maximum of like 10 minutes. And so we will be right back. I'm going to move the judges to the breakout room, and then once they decide on the top 3 ones, we will come back and announce those. So,
okay, great, thanks.
You. Wait, did I make it? Hold on, I think I made a mistake. Hold on.